hosting with B, and I just wanted to introduce a little biography. Dr. B. Hughes, they is a lecturer at Liverpool John Moores University. Their research covers cultural attitudes to and representations of menstruation. B is chair of Liverpool John Moores University College Union and the UCU's national rep for LGBT plus members. So over to B. Would you like to say anything?
Yes, so thanks everyone. It's really nice to be here on International Women's Day to discuss the really important issue of women's health as it affects so many of us, obviously cis women and non-binary people and trans men also impacted by women's health issues. So thank you so much for coming. I hope the discussion is going to be really interesting. Would you like me to introduce you, Teresa?
Go ahead.
So Teresa Williamson is an activist and campaigner who campaigns against all injustice globally and locally. She believes women's healthcare is important globally because women bring all human beings into the world. When women are respected, society is lifted. She looks forward to the day when International Women's Day is no longer celebrated because women are respected all year round.
Thank you. We're going to have two speakers in this section, and our first speaker will be Rebecca Smyth. Rebecca is a member of Save Liverpool Women's Hospital and Socialist Health Association and works as a senior lecturer in midwifery at University of Manchester. As part of her work, Rebecca has collaborated with the World Health Organization in producing international clinical guidelines and is an active member of All Out, LGBT staff network group. So over to you, Rebecca. Can everybody else mute?
Oh, thanks very much, Teresa. I see you took that spiel off me web page in work. It seems very formal, doesn't it? Anyway, you know what? I'm actually only at Manchester until the 31st of March, and then I retire. Bum bum. So I'll have to change all of that, won't I? I'll have to become somebody else, maybe. I don't know. Anyway, basically, I'm a midwife. And so that's where I'm going to talk to you. I think we had 5 minutes. So there's a lot to pack in, and what I thought I would cover is so I want to talk about maternal deaths. Actually, that's what I want to talk about. I want to talk about maternal deaths, the numbers, the causes, the characteristics of the women. Then I want to talk about a bit more detail about suicide in pregnancy. It's something that doesn't really get spoken about, I think, in society anyway, but certainly with pregnant women. And then I want to kind of link it to the suicide and pregnancy and the lockdown. And I don't know, if we have a bit of time, I have made some notes about stillbirth and its association with inequalities. So if I can just tell you a little bit, okay, so about maternal death. So we do reports every number of years in maternal health in a way of capturing how many women are dying and information about them, so we can learn lessons. That's the idea. And so in the report, the most recent report, which is looking at the years of 2016, 17 and 18, they cover 3 years, is the way we do it. We had 217 women that died either in their pregnancy or within the first 6 weeks following the birth of their baby. And we had another 330 women who still described as maternal deaths. And these are from after the 6-week period up until a year. So what do we know about these women that have died in pregnancy or soon after? Well, we know that the death rate is going up. You'll read lots of reports that will say that actually the death rate isn't going up, because they say that the deaths are quite small and we need to, but actually if you look at 2015, 16 and 17, there were 9.6 deaths per 100,000 maternities, per 100,000 births. And in 16, 17 and 18, there were 9.71. And if you look at the data, it's certainly increasing both direct deaths and indirect deaths as to how we split these types of deaths up. So the direct deaths related to the pregnancy, indirect deaths, woman's died, is pregnant at the time, but thought not to be related to the pregnancy, maybe an illness that she had prior to pregnancy. The report concludes that actually, if improvements had been made in the type of care that women have been provided with, differences in outcome could have been altered in over half of those women. Now, differences in outcome when it's death is either live or die. There's no kind of half dead or half alive. If there's differences in outcomes and you're looking at maternal mortality, well, what you're saying is a woman therefore would have lived and not died. So out of those 217 women, they're actually saying differences in care would have prevented their death. So therefore those deaths are avoidable. The other thing, and that I think always when, and I hope I do it, that whenever I do talk at any point about maternal deaths, is to think about who are the women that are mostly dying. And again, from the last 3 years of report to this 3 years of report, there remains a fourfold difference in death rates amongst women of Black and ethnic backgrounds compared to their counterparts of the white women. So a fourfold difference, if you're Black, of dying in pregnancy or soon after the pregnancy. If we look at women of Asian ethnic backgrounds, almost a twofold difference as well compared to white women. So numbers wise, if you like numbers, 34 Black women will die per 100,000 women given birth. 15 Asian ethnic minority women will die per 100,000, and 8 white women. So 34, 15, 8. And when you think about the fact that that report said that these deaths are avoidable, you know, you think about, well, what is the real, why are these women dying? What are the causes of these women's deaths? I know we've spoken at previous meeting about just pure racism is the reason why. You can fancy it up with all of the illnesses and things like that, but I believe that that is the reason. But I'm going to give you some of the more objective reporting that goes into these reports. So we know that if we look at indirect causes, so reasons not related to the pregnancy, the largest single cause of death is heart disease. Second largest is epilepsy and stroke. Epilepsy's had a massive increase, by the way, sudden unexpected death in epilepsy, massive increase in the last 3 years. If we look at direct causes of death, these have not changed since 2013. These results have not changed. Mostly blood clots is killing women during pregnancy and up to the 6 weeks. And then the second biggest cause of death is hemorrhage and suicide. So it's suicide and hemorrhage that are the cause of death for women during pregnancy and the first 6 weeks in their pregnancy. And then if we look at
1 minute, sorry.
1 minute, okie doke. So if we look at suicide, if we look at also deaths from 6 weeks up to a year, it's suicide that is the biggest cause of death. What do we know about these women that are committing suicide? The median age is 30. 86% of them are white ethnicity. 71% have a family multiparous, so that they've got other kids, they've had other pregnancies. 39% are known to social services. 24% say they've got there's a known history of domestic abuse, but actually it's going to be much higher than that, because 59% of women, we don't actually know the answer to that question. And there's other data that tells us that women that don't answer that question actually have a higher increase of domestic abuse, which I've got information about that. Majority of the women received antenatal care, however, not as many visits and attendance as they should have done. And I don't think I have time really, Teresa, do I? I think I probably, no, okay. But I've got some information about women that have died during lockdown and through being murdered through domestic abuse during the lockdown period of COVID as well. But I'll leave it there.
Thanks,
Okay.
Rebecca. Can
Thanks,
I just
Teresa.
say, when we have the questions and answers, you'll have time to speak about that, and it would be really important if you did. So thanks very much for that. Our next speaker is Felicity Dowling. Felicity is a principal speaker for Left Unity, the UK's new radical left party, a teacher, a trade unionist, and a long-time campaigner locally and internationally for children, women, and working class communities. In the 1980s, she was a surcharge councillor in Liverpool during the epic struggle against Margaret Thatcher. Woo! Well done, Felicity. Over to you. You've got 5 minutes. I'll give you a shout when you've got one left.
Thanks. Thank you for the that introduction. I came into this issue of women's health really through the work on the on To Save Liverpool Women's Hospital. It's still there 5 years after we started campaigning, and we think that's really important, but nothing in the NHS is safe at all. We have to continuously campaign and fight. Now, we wanted to make sure there was a women's hospital in Liverpool, and there'd been a women's hospital in Liverpool for hundreds of years. But now we're the only distinct women's hospital, the only one which really stands alone in the whole country. There is one in Birmingham, but really it's pretty much merged with the local hospital. So it's desperately important, as far as we're concerned, that we keep a women's hospital, because medicine fundamentally is aimed at men, and we are the subgroup that has to be considered separately from it. Indeed, there was a woman, I'm sorry, I forgot her name, but from one of the Royal Colleges, who was asked why women's health was secondary, and she just said because they regard men as the main item to be studied. So yeah, we want to make sure that women's health is considered and considered seriously. We've realised that the life in good health for women and for men, but particularly for women, is reducing. The length of time in which women are healthy, it is coming right down. That once a woman is roughly 60, it's regarded that she would be expected to have ill health, to have some level of disability. And that is completely unacceptable. We should not tolerate it, and especially not tolerate that the age is coming down at a time when women are told they can only retire at 68. It is crazy. The same government that publishes these facts about women's life in ill health also publishes the rules about retirement. And pity help any nurse who's been 68, 69 during this pandemic. Pity help any doctor or healthcare assistant. We know that poverty directly affects the outcomes of women's health. We know that in heart disease, men get twice the number of treatments that women do, and yet it's one of the biggest killers of women. It kills far more women than breast cancer does. And yet still the basic health messages on heart disease don't really cover the symptoms that women suffer. I spent an interesting couple of days being with my mother in hospital some years ago in a ward where women had heart attacks, and their stories were fascinating. mean, it was always interesting to be in a women's ward and listen to the women chatter and talk, but their descriptions of what happened to them young women having heart attacks was really interesting. We have issues around contraception. The contraception, side effects from contraception are acceptable for women, but not for men. And still to this day, we have young women and putting up with craziness in order to have contraception. And then others, you know, on a kind of social, those who are considered to be socially unacceptable being injected, whether they want it or not, basically, to make sure they don't conceive. Inflammation diseases or basically autoimmune diseases massively affect women. And then women have this double burden of working both at home and work in the workforce. I was quite not shocked, but a bit moved to see the figures for the amount of housework and childcare that children have done during this pandemic, how they have taken over the roles of their mothers while their mothers are working in a way that hasn't happened with young boys. And obviously, I mean, these area, the issue of menstruation, that menstruation can still impact on women's health. And although there was a brilliant campaign that tried to make sure that period poverty in schools was abolished, still a lot of schools still haven't taken up the offer of the free menstrual products to be there. Actually makes me quite sad because we had it locally quite well boxed off. Literally, the red boxes were going regularly into the schools before this, before the government offered them the money. So depression and anxiety and mental health obviously are also very important areas, and the cuts in mental health could be a meeting entirely on its own. And I think maybe we should be thinking at some point of planning that, because it is catastrophic what's happened. So I'm going to finish on the fact that we have to campaign for women's health and for women's health care, and make sure that what's coming up in the white paper, which is really dangerous for women, is well presented to everybody. The white paper is not a thing of reducing privatization. It in fact concentrates privatization and will have boards at regional level which will be allowed to decide what treatments are available throughout their area. And frankly, my experience of such boards is that I don't trust them, and I want to make sure that we have women's health absolutely up in the front of the campaign against this white paper. Thank you.
Thanks, Felicity. I mean, on women's health, we could just go on and on for hours and never tire, but thanks for that. If anybody wants to ask questions or say anything, B will mute and unmute, and if you can just put your animated hand up would be great. So, switch that off. Yeah. Would anybody like to ask a question or to make a comment?
Yeah, I can see Hannah would like to speak, so I'll unmute you, Hannah.
Thanks. So it's a question for Rebecca. So you talked about the excess mortality amongst Black and Asian women in terms of maternal mortality. And you went into a bit of detail about some of the reasons, some of the causes of death in those populations. But would you be able to speak a little bit more about how racism impacts upon the care of Black and Asian women in antenatal services and in hospital? Because I think some of it is might seem obvious, but I think actually there are lots of subtle ways that racism impacts on women's health generally. But if you could speak to that a bit, that would be great.
Thanks, Hannah. I think I suppose the way I see it is that there are definite inequalities that in our society, Black people will affect them way more than others. And so, for instance, if you say that Black people may have more hypertension, more diabetes and more of these kind of medical problems. Actually, when you look at society, it's the poorest and the most marginalized people that have those problems. And therefore, I think to myself, well, actually, what is going on with society that makes then that a group of people are way more marginalized than others? I mean, for instance, in you could also in the antenatal care, for example, there could be difficulties. I mean, we've got things like charging for migrants and things like that, and you know that people will just decide who's a migrant based on profiling and things like that, and maybe then treat them differently. But if people, we have to accept that racism is within the society, so it's going to be in hospitals as well as to with healthcare professionals and how they will treat women. And therefore, if a woman has had a poor experience, for example, of accessing healthcare, not had a good experience, you may well be less likely to try again and come back again. There may be some people that there's things written that maybe Black and ethnic minority women are more likely to they may feel as though they're being awkward or asking things, and just less likely to ask for what is their rights. I don't know whether I'm answering your question fully, but it's things like those things that I think that it's easy. Why is it we've got the women dying? And I don't think it's just because of the fact that they've got these morbidities associated. I think, white women have those similar morbidities. There must be more going on that prevents them from accessing healthcare as early on, they come to. I mean, we know that in the last report, they did say that, there were cases where it was 100% evident in this report that women not accessing healthcare because of the fear of being charged did definitely impact on the reason why they died. So I don't know if others want to add as well, but I think it's definitely associated with racism.
Thanks, Rebecca. Is there anybody else who would like to ask? Oh, Greg's got his hand up.
Okay, so you're unmuted now, Greg.
Thanks. I just wanted to comment on this question. My understanding of it is that poverty, deprivation, occupation, comorbidities, all of those things don't fully explain the differential between different ethnicities. And in terms of COVID, it's actually more men than women, but there is a kind of definite ethnic gradient for both men and women. And the studies have controlled for all these other factors, and they don't fully explain it. They partially explain it, but not everything. And that strengthens the idea that it is actually about structural racism, although it could be biology, but that's unlikely. So anyway, if somebody says, oh, it's because Black people are living at the bottom of society, well, that doesn't seem to be the explanation, because you can take that into account when you do the studies.
Thanks, Greg. Louise? Yeah, Louise.
Yeah, you're unmuted, Louise, go ahead.
Hiya, I just wanted to kind of bring up another topic, as if there weren't enough in women's health as it was anyway. But when you started talking about maternal deaths and maternal suicides and all that really grim stuff, one of my questions was, the first thing that came to my head even was, I wonder if more open, easier access to abortion would prevent this, because it's legal in the UK, but you still have to have 2 doctors sign off on it. You still have to take time off work to go in for the procedure. It's horrific, it's not something anyone delights in doing. No one is using it as a form of contraception, and yet it is still restricted. And in some cases, we've seen with Nadine Dorries, for example, almost legislated against. And my question is, if it was made more accessible and more accepted even, would that have an impact on those numbers? I'm done.
Who's that to? Anyone in particular, or?
Rebecca or Felicity, to be honest, anyone can jump in on that. It's just a discussion that I'd really like to have.
I think that's it's an interesting point, Louise. I've got to be honest with you. The answer is that I don't know, and I haven't read particularly. There must be something out there to read and what have you, and learn more about it. The thing is, the reporting, even in the confidential inquiry, is really quite limited to even kind of delve into, well, why have the women committed suicide? You know, what's their reason? What is going on? And some of them, you know, have had mental health problems prior to their pregnancy. Others, there doesn't appear to be so. So the answer is I don't really know, and I don't think we know enough about, or I don't know enough about what the causes are of these deaths, other than they are, you know, in lockdown, they certainly, I think there were women that were known to the service, that were known to have problems, and because of lockdown, they seem to just get lost somehow and didn't get that face-to-face meeting, even if by Zoom, where you can kind of get a sense of how somebody is. That just didn't kind of happen. But what their reasons were, I'm not answering you, I'm sorry. But it's an interesting point, Louise.
Thanks, Rebecca.
I can see Hannah's got her hand up again. I just want, if I can make a brief comment as well. I'm thinking that, you know, access to abortion is part of the wider need for better access to reproductive health care and women's health in general, and also mental health links to all of these things. So I think it would be a better thing for reproductive health care and women's health to make abortion more available when needed in general, and that is part of the wider system of things that are failing pregnant people and people, you know, and women at the moment. So I think that it's probably all bound up in all of these other things, and it's also kind of the fact that these maternal deaths are not being reported and investigated in much detail speaks to the long history of not paying attention to women's health enough or at all. Part of my research, I looked at the long medical history of sexism, and it was just mind-blowing. But yeah, I'm going to be quiet because we've got Hannah's hand up and Teresa's hand up. So should we go to Hannah first?
Thanks. So just on the abortion thing, so one of the interesting things that's happened during the pandemic is that we've actually had a slight liberalisation of abortion, access to abortion, because what they introduced to try and deal with the fact with, you know, not bringing women into clinics for assessment was they introduced telephone assessment and then sending out the medicine for a medical abortion to people at home. And I've just put the link for BPAS in the chat there. BPAS have led a campaign to try and sustain this, and they consistently campaign for further decriminalisation of abortion here in England and also in all of the regions of the UK. So it's worth having a read of what they're up to. And they've contributed to an inquiry recently to try and continue access to telehealth for abortion services for all early medical abortion. So I think that's one of the strange benefits, side benefits of the pandemic, if that can continue, because that will actually allow women to access safe abortion at home with proper advice available for if and when they need it. I'll just say that also that maternal deaths are usually investigated. It's whether we're learning enough from those maternal deaths. So now it's absolutely routine. We shouldn't be having any maternal deaths or any avoidable maternal deaths. And so NHS trusts are obliged to investigate them. It's whether we're able to learn lessons from them and change practices that actually make things better, particularly for the subgroups that Rebecca's talking about, you know, Black and Asian women particularly.
Thanks, Anna.
Can I just check, Felicity, did you wave a moment ago or not? Would you like to come in after Teresa? Would that be okay?
Yeah.
And then we'll
fine.
go to Mandy.
Yeah, I just wanted to say as well, before contraception came in, women had no control over their fertility, how many children they had, as we know back in the day, 16, 18, 20 children at times. And now, because of abuse in relationships, a lot of women still don't have that control because there are abusive partners, predominantly men out there, who keep women pregnant. So it's like a conveyor belt of one baby after another. So she's in the house, she has no time to do anything other than look after these children because those partners are out and about, and even if they're not working, they make sure that they're vacant from the home. They don't want to get involved looking after the children. So there's also that as well. So people may have said, oh, it liberated people. I think middle-class women were liberated when contraception came along. I don't know about the rest of the women, but there's also that as well. And another thing I did talk about one time at one of the board meetings at the Women's Hospital, I spoke about women with addiction who don't feel safe enough or feel they would have the confidentiality to be able to say, I'm a drug addict, I'm an alcoholic, I need some help, but I don't want somebody catching my baby at the end of the bed when I deliver it. That is still not there. And they didn't have an answer for that neither. They just said, oh, well, we don't really check. But there are women out there who are addicted, who would like to get help, who would like to have a healthier baby and make sure that their health is good, but they're suffering in silence. And I think that's dreadful in 2021, to be honest with you. Don't know if Rebecca knows any different to that on those vulnerable women being able to reach out.
No, I think that's why we're having the death rate, Teresa, that we're having. Do you know what I mean? I think it just, unfortunately, it does link with that, doesn't it?
Thanks.
Yeah, thanks for that really important point, Teresa. Yeah. Felicity, I'll unmute you now and then we'll go to Mandy afterwards.
Take Mandy first, go on.
Okay, Mandy, over to you.
Hi, yeah, I was just going to ask Rebecca, my daughter gave birth last May during lockdown in the women's, and she had a really hard labour which had gone on for days, and 3 times I had to take her to the door and leave her to walk into the hospital on her own in absolute agony. Because there was, I wasn't allowed in until she was in established labour, and even then, after she'd given birth, I had to leave very quickly after the birth, and then later on in the autumn, she got appendicitis and had to go and have her appendix out in the Royal, and she was breastfeeding, and we had to cope with the baby, trying to get him to feed from a bottle, and they wouldn't let him come into her to be fed, and we had horrendous times, or she had horrendous time. And I have heard also that women can't have birth partners with them when they're going in for scans, when they might possibly be getting bad news about their pregnancy and the baby. And I just wondered if anything has changed in any of those things, or if there's any prospect of anything changing. Thanks.
I mean, there's probably people on in the group here that know more about the women's. I don't know specific about the women's, Mandy, but I know things have improved, I guess, and that there is now people are allowed to go with their partners for appointments and things like that, for what is considered important appointments and things like that. So I think they have. I don't know, it's a difficult one. I think that initially people just I would like to say did what they thought was the right thing the time. You know, if your daughter was in March, April, May, it was literally just weeks after. You know, I'm not saying it was the right thing to do, but I do think clinicians were trying to do the right thing to keep everybody safe, you know, in all fairness and everything. For it to continue, no, there's no, you know, we know a lot more about it now, and, you know, there's more PPE around and things like that, so people can be protected more, and family can come in, and as long as they, you know, the partner is wearing a mask and things like that, I don't see any reason. But I mean, people here will probably have more of an idea of what's going on with the particular women's, but I just know that things have gone a lot easier and a lot more welcoming. In the general side of things, I don't know. I'm not, yeah. But I think that is anybody else? Teresa, you maybe know more about, or Hannah, sorry.
Yeah, Hannah, you.
I can answer that quickly. So the women's have changed their policies slightly, but they're still only allowing birth partners to be there for active labour and birth, unless there are extraordinary other circumstances. I know this because I'm 4 weeks away from my due date, so I've been planning a home birth to avoid that situation, with the wonderful home birth midwives from the women's. So they're still part of the women's team, there's still a restriction on who can come in for your scans, all of these things. I think they have made the problem with this is that actually this is a bit of a postcode lottery across the country. So different hospitals have adopted different policies, and actually there's not much unity, not much guidance about it. More broadly, we've been quite slow at collecting data about COVID in pregnancy and getting that data out there. So there was initially a kind of a feeling that pregnant women were no more at risk, and that we didn't need to worry too much about pregnancy and COVID. Now there's data, particularly from the US, that suggests actually we do need to worry about it. There are more adverse outcomes for mothers and babies where they've had COVID. And that's not only related to the severe forms of COVID, it's related to risk of blood clots and things like that. Again, it's another example of pregnant women and breastfeeding women being kind of left to the bottom of the research heap. You'll all be aware that the vaccines have not been tested in pregnant women and breastfeeding women, so that means that there's no direct evidence about whether we should have them or not, and whether they're safe or not. And we're collecting that information post hoc. It's another good example of research and health systems not being geared to meet the needs of women.
Thanks, Hannah, to all the women that bring every human being into the world, and congratulations as well. Wonderful. Is there anybody else who would like to ask a question who maybe we can't see? Oh, sorry, it was Felicity, wasn't it? I do apologise, Felicity. You were waiting in the queue. Sorry.
Let me unmute myself.
Oh,
sorry, I did it and now you've remuted. I'll do it again.
You do it again. Okay, thank you. I want to raise a couple of things around the mental health issues for women who've just given birth. First of all, the impact of a horrific birth, a terrifying birth, is simply not addressed adequately by the hospital. There should be a package there in place to support that woman's mental health going forward and continuously, But we've had instead, just before when the pandemic started, something like 2/3 of health visitors were diverted from their roles into other pandemic roles, and therefore the very basic support at home was not available to very many women. Now, I don't know whether there's going to be more suicides amongst women at the end of the pandemic or not. There is some indication that the kind of general feeling that this is all awful for everybody is some sort of protection. But I've been following a couple of absolutely horrific cases and they came out of basically neglect on the labour ward. Not neglect that the individual staff could do anything about, but the fact that the system simply is understaffed and under-equipped. On the racism issue, one of our meetings, our live meetings, you know, before the pandemic, when we actually met in person, we had a discussion about the racism in childbirth. And one of the Black women who was there was saying, listen, we always take our mothers with us because our mothers will argue the case for us and make them listen and make them understand what we're saying, not understand in the sense of language, but make them heed what we're saying, because otherwise they felt completely unheeded in labour. That shocked me and really was something I think we need to be thinking about. We need to be discussing with Black women about what this is. And I believe that is going on a bit more than it has been doing. I'm grateful for, you know, to Hannah for the comments on the abortion, because I too had seen that. I thought the abortion situation has improved and during this pandemic. But one interesting thing that we very rarely discuss is what actually leads to women having babies. What we know the physical process, but what's the decision process? And I know there's the horror stories that Teresa's told, but otherwise, we asked this at the women's once at the board meeting to say, how do you plan for how many babies are likely to arrive? And the responses were frankly, they were just annoying. It was flippant, like, it depends on how many goals that Liverpool scores and things like that. There isn't a proper study on that decision to have a baby and how it works. And then, you know, the issue, until we've got that decision going, that discussion going, and we really look at how that impacts on mental health, I think we're going to have a continuation of the issues. But the other thing I want to raise is these scandals that have arisen in Shrewsbury, in Morecambe, in many of the areas where, you know, women have been given birth. And then today, there was an announcement that those hospitals would be fined and fined a hell of a lot of money by the insurance company that's part of the NHS. Which means they will be deprived still further of money. And what bloody good does that do? Yes, people should be sacked for their roles in those scandals. But personally, I think those scandals all go back to better births, to the maternity review, which was pushing and pushing and pushing the fact that there should be home births and there should be, let's get births as cheap as possible. Let's bring the price of births down, and really pushed to an extreme the idea of natural childbirth. Now, I'm an absolute exponent of natural childbirth. I think it's a fantastic, you know, thing to aim for, but it doesn't always work. And that's got to be, you know, people have got to be aware of that. And the final thing, just some people will have heard me say this at women's meetings before, that my daughter-in-law, who's Albanian, was told, giving birth twice when she was giving birth in Britain, that, oh, clearly Albanian women have different pain thresholds to English women. It's just so condescending and horrible that, you know, I mean, she can normally wipe the floor with anyone who makes any kind of derogatory comment. But as you're giving birth, it's not really easy to come up with your, you know, your backswipes in terms of comments. So I think there's a major underfunding, major management issues, major bullying issues amongst management in the maternity service, all of which need addressing.
Thanks, Felicity. I think we'll be coming to the end just now and probably be thrown back into the main room, so be aware. Does anybody, I mean, Alice came up with a great idea, safe International Maternity Day, was it? What was it Alice said, which was a very good...
Yeah, something like, International International Safe Maternity Day, something like that.
Yeah.
I think it's really important that the elements on safety, not just awareness.
Great idea, Alice. That'll be coming soon. Are there any final comments from Rebecca, Felicity, or if anybody, or Hannah, anybody has a quick comment? I mean, it's been a great discussion anyway, and I'm sure people have learned a lot, and there's still lots more to learn. But yes, I always say that women's health should be at the top of the agenda. They've brought 7.7 billion people into the world. No mean feat. Thank you very much. So I think because healthcare has always been dominated by men until the last, maybe few decades, where now we've got women there. And I still always think the women's hospital should be run by women and led by women, and we've got all the expertise there. And yet it's still male dominated in a lot of ways. So, we've still got a long way to go. It shouldn't be this hard. If not now, when? That's all I can say. Can I just say Louise was responsible for putting the lovely biogs together? It wasn't me. I'm not going to take credit. She's juggling a baby as well, so next generation she's juggling. But yeah, I think it's been a really good discussion, and thanks to Rebecca and Felicity and Hannah. There's my alarm going off.
Very quickly, there was lots of people have put really great links in the chat. Could somebody save the chat and circulate those links for us? Because I put one in about the Black Mum Magic project, which is a really great project to find out about Black and Asian women and perinatal health in Cheshire and Merseyside. And then there's some other links that B has put in that are really important too. So
yeah. And if anyone wants to save it, the 3 little dots next to file, if you click on that and save chat, it will save in a folder on your computer or whatever, so you've got it there as well. But just like to say thank you to everyone, and to B for co-hosting. Sometimes you think to yourself, what do I have to do next? But it's been really great anyway, and just so happy for Hannah. Can I just say that again, because I am. Well,
yeah, thank you so much, everyone, for your time and your participation, and Teresa for main hosting, Rebecca and Felicity for your contributions, and everyone else for those two. It's been a really
and for Mandy's as well. Just really sorry that but it's hard, isn't it? Because no 2 births are the same. You never know when you go in, do you? Goodness me. With or without COVID.
Yeah, please send our solidarity to your daughter.
Yeah. What did you say?
Can I say to Mandy that at the last women's board meeting, they did say that things had been relaxed in terms of who could be there. But I do think that it's wrong, that it's horrible to think of women being on their own in the early stages of labour. It's not human. And it's, it has to stop.
Absolutely.
Do we wait until we're thrown back into the main room? Because I don't have a clue.
Well, I'm not sure if Tessa could just make us all go. But I think if we've finished our discussion, then we can all click leave room and it will take us back to the main room. Let me just have a check and see what's happening. So most people are still in their breakout rooms. So I don't know if we want to just stay here until we're forced out, or if we want to migrate back into the main room. It's entirely up to you. I tell you what I will do though, I will stop the recording so that people can speak off record if they want.
Great. Well,
can I ask for